Myself, Dr. Rajesh Sharma. I am a senior cardiologist at Saroj Institute, and today we are here to discuss about the latest update in hypertension. So, as per WHO latest data, nearly 63% of the population worldwide in India is suffering from non-communicable diseases, of which 27% are attributed to cardiovascular disease and which affect 45% of the people in 40 to 69-year age group. So raised blood pressure is among the most important risk factors for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. So if we see the latest data from Lancet published by WHO, so in India, the prevalence has also gone up over 30 years to 38% in men and 32% in women over 30 years of age. And despite all the awareness efforts, over 50% of the population, means 62% of men and around 53% of women living with hypertension, did not get the treatment. So medication was used in control of BP in fewer than 1 in 5 in men and 1 in 4 in women worldwide. So, if we see the International Society of Hypertension released guidelines for 2020, the inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource poor settings. So, optimal care refers to evidence based standard of care, and whereas essential standards refers to minimum standards of care to allow specification of essential standards of care for low resource settings. So if we see the AHA ACC scientific statement for 2021, there are some new guidelines for management of stage 1 hypertension, especially among patients with low ASCVD risk. So among low risk patients, those who have a 10-year CVD risk of less than 10% and who have a stage 1 hypertension, management starts with non-pharmacological therapy like lifestyle management, lifestyle modifications. And if blood pressure remains uncontrolled after 3 to 6 months, then we should consider starting some pharmacological therapy. So, and if there is some more interesting data also available regarding ARDS in potentially fatal, which is a potentially fatal condition among with lung damage, especially in this COVID-19 era. So, in the recent study, which appeared in the Journal of American College of Cardiology, that reports that metoprolol can reduce lung inflammation and rather improve the respiratory function in people with COVID-19 induced ARDS. So, this is very interesting data because beta blockers are supposed to deteriorate the condition in COPD patients and especially these lung inflammation patients. So this is interesting data. So lowering and one more interesting data is which has reconfirmed the findings of the SPRINT study, which was published few years back, is the STEP randomized trial, which is recently published and which again emphasized that lowering blood pressure targets down to 110 or less than that, rather than 130 millimeters of mercury, will substantially reduce the CV adverse events. So this study was done among more than 8,000 patients of 60 to 80 years of age in China, and the intensive target trimmed 26% of the composite CV risk. So these findings from now a second major trial supporting a lower target could unite the guidelines, which even among the US professional societies range from threshold of 130 to 150 millimeters of mercury. With regard to prognostic value of ambulatory BP monitoring and nighttime blood pressure monitoring, the 2018 European guidelines on the management of arterial hypertension recommend that diagnosis of hypertension should not only be dependent on the office BP or the clinic BP, but also out of the hospital or out of the office measurements such as ABPM or home BP monitoring. So 24-hour and nighttime BP measurements were associated with greater risks of mortality and composite of CV outcome. So thus, they may be considered as the most relevant measurements for estimating the CV risk. And for every 20 by 10 millimeter mercury increment of BP at night, the risk of mortality increased by 23%, and the risk of cardiovascular events rather increased by 36%. So ABPM and home BP monitoring has become significantly important, especially to start the treatment. And we should not only depend upon the office BP measurements. So one more interesting data recently published is that most patients with hypertension require lifelong therapy, as we know, but which therapy we should start with and how to start with. So, as per 2018 European guidelines, they recommend five classes of antihypertensive drugs, as we know, and considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve the adherence to therapy and BP control. So now the 2018 European guidelines in this context of lowering BP, even American guidelines, they advocate to start with antihypertensive therapy with an initial dual fixed dose combination like ACE inhibitor or ARB plus either a calcium channel blocker or a diuretic. So there is one significant finding since July 2018 is that valsartan has also been recalled worldwide because of its potential carcinogenic potential, especially in causing some cases of liver cancer. So we'll discuss one more interesting study, which is HYGEA study, which represents the largest study that tested nighttime antihypertensive treatment. So in this trial, a chronotherapy was associated with significant reduction in endpoints, including death. So this HYGEA chronotherapy trial tested whether a nighttime therapy in comparison to the usual daytime antihypertensive therapy exerts a favorable CV risk reduction or not. So in this study, there were more than 19,000 hypertensive patients, and during a follow-up of 6.3 years, 1,700 patients participants experienced the primary CV outcomes. So in an ambulatory BP measurement was performed for 48 hours and to collect data on how BP differed during sleep. So if you see the rate reduction for CV events was significantly improved for nighttime treatment when compared with awakening treatment. Again, more important is that all the patients who are hypertensive, they should receive the treatment because as we can very well see that even now more than 50% of the eligible patient of hypertension, they are not able to receive the proper medical therapy for hypertension. And again, the emphasis or the importance of ambulatory BP monitoring has been highlighted, and it has become more important when it comes to reducing the CV outcomes. So important thing is that we should start the treatment for all the eligible patients of hypertension, and rather we should start with combination therapies to make the treatment more compliant for these patients. And we should understand the importance of reducing the CV outcomes, and the importance of ABPM should be emphasized. Thank you very much.